Well, hello and welcome back to the Functional Anatomy College of Natural Health Sciences Bermuda Induction Prep course. This is week number 9. So after this week, we only have one more week left before this course concludes. And in today's lecture, we are going to be taking a look at Chapter 8, where we will be studying the pelvis, the thigh, and the knee in the Functional Anatomy textbook. The learning objectives for today's lecture are: we're going to identify the main structures of the pelvis, the thigh, and knee, including the bones, joints, special structures, and deep and superficial muscles. We're going to label and palpate the major surface landmarks of the pelvis, thigh, and knee. We're going to identify and demonstrate all actions of the pelvis, thigh, and knee, and the movements that are available. We're going to identify and demonstrate passive and resisted range of motion of the pelvis, thigh, and knee. We're going to draw, label, and palpate the deep and superficial muscles of the pelvis, thigh, and knee, and name their actions. Palpation should include the origin, insertion, the muscle belly, and demonstration of shortening and lengthening of the muscle. We're going to describe the function of each of the muscles of the pelvis, thigh, and knee. We're going to identify both the synergists and antagonists involved in each movement of the pelvis, thigh, and knee, such as flexion and extension. And we're going to identify movements and muscles involved in coordinated activities of the pelvis, thigh, and knee, such as running, lifting, throwing, and kicking. We begin today's lecture by taking a look at the surface anatomy of the pelvis, thigh, and knee from an anterior view. The iliac crest is the superior edge of the wing of the coxal bone. The femoral triangle is formed superiorly by the inguinal ligament, laterally by the sartorius, and medially by the adductor longus. The tensa fascia lata is a small hip flexor visible on the anterior lateral thigh. The rectus femoris is a prime mover for hip flexion and knee extension. The vastus lateralis muscle is part of the quadriceps and it forms the bulk of the lateral thigh. The vastus medialis muscle is part of the quadriceps and has a teardrop shape just superior and medial to the knee. The patella is commonly called the kneecap. The patella tendon joins the quadriceps muscles, crosses the patella, and attaches to the tibial tuberosity. And now we will take a look at the surface anatomy of the pelvis, thigh, and knee from a lateral view. Beginning from the left-hand side most superiorly, we see the gluteus medius. The gluteus medius is the prime abductor of the hip. The gluteus maximus is one of the most powerful muscles in the body. The biceps femoris is the most lateral of the hamstring muscles. The iliotibial band is a large, thick tendon associated with the tensa fascia lata and gluteus maximus muscles. It attaches to the anterior lateral condyle of the tibia. The head of the fibula is an insertion point for the biceps femoris. The greater trochanter of the femur is a prominent bony landmark and insertion point for most of the gluteal muscles. And now let's look at the surface anatomy of the pelvis, thigh, and knee from a posterior view. Beginning from the left-hand side most superiorly, we see the adductor magnus, which is the largest adductor of the thigh. The semimembranosus is the most medial part of the hamstring group. The semitendinosus lies medial to the biceps femoris and is part of the hamstring group. The gracilis is the medial adductor of the hip. The pes anserine tendon is named for its three-pronged goose foot shape and is formed by the insertion of the sartorius, gracilis, and the semitendinosus. The popliteal fossa is a hollow on the posterior knee. Its borders are formed by the hamstring and gastrocnemius muscles. And here we have the bones of the pelvis, thigh, and knee from an anterior view. The pubic symphysis is the medial junction between the right and left sides of the pelvic girdle. It is slightly movable cartilage joint. The tibial femoral joint is a modified hinge joint that allows flexion, extension, and slight rotation of the knee. At the patellofemoral joint, the patella glides inferiorly as the knee flexes and superiorly as it extends. This maintains the leverage of the surrounding muscles during movement. And here we see the bones of the pelvis, thigh, and knee from a posterior view. The sacroiliac joint is a large stable union between the lateral sacrum and the medial ilium. The linea aspera is a long vertical line running along the shaft of the posterior femur. It is the site of several muscle attachments. And here we have the bones of the pelvis, thigh, and knee from a lateral view. Notice the red outline on the illustration here. It illustrates the outline of a female pelvis, which generally is wider and more horizontally oriented than the male. The acetabulum is the deep socket formed by the fusion of the ilium, ischium, and pubis. The coxal joint is formed between the head of the femur and acetabulum. It is a stable ball and socket joint that allows movement in all planes. And these are the bony landmarks that we can palpate for the pelvis, thigh, and knee. The anterior superior iliac spine, the anterior inferior iliac spine, the iliac fossa, the lumbar vertebral bodies, the rami of the pubis, the adductor tubercle, the medial femoral condyle, the lateral femoral condyle, the medial tibial condyle, the lateral tibial condyle, the fibular head, the tibial tuberosity, the posterior superior iliac spine, the sacrum, the greater trochanter of the femur, and the ischial tuberosity. And now let's consider the ligaments of the pelvis and hip from an anterior view. The iliolumbar ligament is part of a complex network of ligaments that stabilize the pelvic girdle and its connection to the lumbar spine. The inguinal ligament is the inferior margin of the aponeurosis of the external oblique muscle and the superior border of the femoral triangle. The Iliofemoral ligament, shaped like an inverted Y, helps maintain optimal contact between the femoral head and the acetabulum, while it limits medial rotation and extension of the hip. And here we have the ligaments of the pelvis and hip from a posterior view. The posterior sacroiliac ligaments surround and stabilize the sacrum. They are part of a large network of strong, thick ligaments located in the pelvic region. The sacrotuberous ligament stabilizes the sacrum inferiorly and provides muscle attachment points on the posterior pelvis. The posterior sacrococcygeal ligaments anchor and stabilize the small, delicate coccyx. The Iliofemoral Ligament spirals around the posterior coxal joint and assists the Iliofemoral Ligament in limiting medial rotation of the hip. And now let's consider the ligaments of the knee from an anterior view. The posterior articular surface of the patella sits in the femoral groove. The Patellofemoral Joint must slide up and down as the knee extends and flexes. The Lateral Meniscus is a crescent-shaped cartilage that cushions the Tibial Femoral Joint and increases joint continuity. The Lateral Collateral Ligament connects the lateral femoral condyle to the head of the fibula. It prevents lateral opening of the Tibial Femoral Joint or the varus deformity. The patella tendon, cut, connects the quadriceps muscles to the tibia. It is sometimes called the patella ligament because it connects the patella to the tibia. The posterior cruciate ligament connects posteriorly to the tibia and anteriorly to the medial condyle of the femur. Stronger than the anterior cruciate ligament, it prevents the tibia from sliding posteriorly and the femur from sliding anteriorly. The anterior cruciate ligament connects anteriorly to the tibia and posteriorly to the lateral condyle of the femur. It prevents the tibia from sliding anteriorly and the femur from sliding posteriorly. The medial meniscus is a crescent-shaped cartilage that cushions the tibial femoral joint. It has direct connection to the medial collateral ligament. The medial collateral ligament connects the medial femoral and tibial condyles. It prevents medial opening of the knee or valgus deformity. And here we have the ligaments of the knee from a posterior view. The posterior meniscofemoral ligament joins the lateral meniscus and the medial condyle of the femur. The knee is a modified hinge joint capable of flexion and extension. Asymmetry in size between the medial and lateral femoral condyles allows slight rotation at the tibial femoral joint. And now let's consider some of the special structures of the pelvis, thigh, and knee from an anterior view, considering the blood vessels and lymphatics. The superficial inguinal nodes are inferior to the inguinal ligament and drain the deep inguinal nodes. The deep inguinal nodes lie alongside the femoral artery within the femoral triangle. The femoral artery and vein run together with the femoral nerve deep to the inguinal ligament and through the femoral triangle. The popliteal nodes are embedded in the popliteal fossa of the posterior knee. The anterior tibial artery serves the lower leg. The great saphenous vein on the medial thigh runs superiorly to join the femoral vein. And now we consider the nerves of the pelvis, thigh, and knee from an anterior view. We see the lumbar plexus, the obturator nerve, the lateral femoral cutaneous nerve, the sacral plexus, the femoral nerve, the anterior cutaneous nerve, the inguinal ligament, the lateral branch of the anterior cutaneous nerve, the medial branch of the anterior cutaneous nerve, the rectus femoris muscle, the saphenous nerve, and we see the common perineal nerve, the superficial perineal nerve, and the deep perineal nerve. And now we see the nerves of the pelvis, thigh, and knee from a posterior view. The sciatic nerve lies deep to the piriformis muscle. It runs down the thigh before trenching into the common peroneal and tibial nerves at the popliteal fossa. The common peroneal nerve lies lateral to the head of the fibula. The popliteal artery and vein lie within the popliteal fossa along with the tibial nerve. Now let's consider the superficial muscles of the pelvis, thigh, and knee from an anterior view, beginning with the iliacus, followed by the psoas, the tensa fascia lata, the sartorius, the pectineus, the adductor longus, the gracilis, the rectus femoris, the iliotibial band, the vastus lateralis, and the vastus medialis. And here we have the superficial muscles of the pelvis, thigh, and knee from a lateral view. We see the gluteus medius, the gluteus maximus, the vastus lateralis, the biceps femoris long head, and the biceps femoris short head. We can also see the sartorius, the tensa fascia lata, the rectus femoris, the vastus lateralis, and the iliotibial band. And here we have the superficial muscles of the pelvis, thigh, and knee from a posterior view. Beginning from the left-hand side most superiorly, we can see the adductor magnus. We can also see the semitendinosus, the gracilis, the semimembranosus, and the sartorius. And from the right-hand side, beginning most superiorly, we see the gluteus medius, the gluteus maximus, the iliotibial band, the biceps femoris long head, the biceps femoris short head, and the popliteus. Now let's take a look at the deep muscles of the pelvis, thigh, and knee from an anterior view. We see the psoas, the iliacus, the pectineus, the adductor longus, the gracilis, the vastus lateralis, the vastus intermedius, and the vastus medialis. And now we'll look at the deep muscles of the pelvis, thigh, and knee from a lateral view. Beginning from the left-hand side, most superiorly, we see the gluteus medius cut. We see the gluteus minimus. We also see the biceps femoris long head and the biceps femoris short head. And over to the right, most superiorly, we see the iliacus, the psoas, the rectus femoris, and the vastus lateralis. And here we have the deep muscles of the pelvis, thigh, and knee from a posterior view. We see the gluteus medius cut. We see the gluteus minimus, the piriformis, the gemellus superior, the obturator internus, the gemellus inferior, the quadratus femoris, the semitendinosus, and the biceps femoris short head. The general techniques for palpating muscles are to first locate the origin, then locate the insertion, followed by locating the muscle belly. We then activate the muscle using resistance, we shorten the muscle, and we lengthen the muscle. And here we see the muscle attachments of the pelvis, thigh, and knee from an anterior view. And here we see the muscle attachments of the pelvis, thigh, and knee from a posterior view. Now let's consider the motions that are available at the hip. In illustration A, we see hip flexion. In illustration B, we see hip extension. In illustration C, we see hip abduction. In illustration D, we see hip adduction. In illustration E, we see internal rotation. And in illustration F, we see hip external rotation. And the motions that are available at the knee are illustration A, flexion of the knee, illustration B, extension of the knee, illustration C, internal rotation at the knee, and illustration D, external rotation at the knee. Now let us consider the purpose of passive and resisted range of motion. Passive range of motion helps to establish the health and function of inert structures such as the joint capsules and the ligaments. Resisted range of motion helps establish health and function of dynamic stabilizers and prime movers. It helps to identify balance and potential imbalance between muscles that steer and power the lower extremity. And now let's look at the illustrations of passive range of motion at the hip. Illustration A shows passive flexion. Illustration B shows passive extension. C, passive abduction. And D, passive adduction. E demonstrates passive internal rotation, while F demonstrates passive external rotation. Now let's consider passive range of motion of the knee. Illustration A demonstrates passive flexion of the knee, while illustration B demonstrates passive extension of the knee. Illustration C demonstrates passive internal rotation of the knee, and illustration D demonstrates passive external rotation of the knee. Now let's consider resisted range of motion of the hip. Illustration A demonstrates resisted flexion of the hip. Illustration B demonstrates resisted extension of the hip. Illustration C demonstrates resisted abduction of the hip. Illustration D illustrates resisted adduction of the hip. Illustration E demonstrates resisted internal rotation of the hip. And illustration F demonstrates resisted external rotation of the hip. Now let's consider resisted range of motion of the knee. In illustration A, we see resisted flexion of the knee. In illustration B, we see resisted extension of the knee. In illustration C, we see resisted internal rotation of the knee. And in illustration D, we see resisted external rotation of the knee. So now let's consider the synergists and antagonists for the hip. For flexion, we have the psoas muscles, the iliacus, the sartorius, the tensor fasciae lata, the rectus femoris, the pectineus, the adductor brevis, longus, and magnus, and the gluteus medius and minimus. And for extension, we have the adductor magnus, the gluteus maximus and medius, the biceps femoris, the semimembranosus, and the semitendinosus. So now let's consider the synergists and antagonists for the hip for abduction and adduction. For abduction, we have the sartorius, the tensor fasciae lata, the piriformis, the gluteus maximus, medius, and minimus. For adduction, we have the pectineus, the adductor brevis, longus, and magnus. We have the gracilis, the gluteus maximus, the gemellus superior and inferior, the obturator internus and externus, and the quadratus femoris. The synergists and antagonists of the hip for internal and external rotation are as follows. For internal rotation, we have the Gluteus Medius, the Gluteus Minimus, the Sembraeonosus, and the Semitendinosus. For external rotation, we have the psoas, the iliacus, the sartorius, the adductor brevis, the gluteus maximus and medius, the piriformis, the gemellus superior and inferior, the obturator internus and externus, the quadratus femoris, and the biceps femoris. Now let's consider the synergists and antagonists for the knee. For flexion, we have the sartorius, the gracilis, the biceps femoris, the semimembranosus, the semitendinosus, the popliteus, and the gastrocnemius. And for extension, we have the rectus femoris, the vastus lateralis, the vastus intermedius, and the vastus medialis. Also for the knee, the synergists and antagonists for internal rotation, we have the sartorius, the semimembranosus, the semitendinosus, and the popliteus. For external rotation, we have the gracilis and the biceps femoris. Now let's consider the coordinated movements of the pelvis, thigh, and knee, beginning with running. Alternated opposite motions of the hips and knees drive the running motion. Powerful hip extensors and knee flexors bring one leg back as the other drives forward using the hip flexors and knee extensors. The body maintains its sagittal plane motion through the stabilizing efforts of the deep six external rotators as well as the adductors and smaller gluteal muscles. Now let's consider the coordinated movement of lifting. The hip and knee must work in concert with the trunk and upper body to lift objects from the ground. Powerful muscles like the gluteus maximus and quadricep muscles drive the motion, while stabilizers like the gluteus medius and the adductor group of muscles maintain a steady body position. Now let's consider the coordinated movements of throwing. As with running, throwing requires different movements on each side of the body. This movement is more complex because it takes place in multiple planes. The front, or lead leg, plants while the body rotates around it, bringing the chest and arm forward. The quadriceps, hamstrings, and gluteals accept the body's weight, while the rotators of the hip and knee pivot the body around the foot. The back, or trail leg, uses the adductors to control the motion before swinging through and accepting the body's weight for the follow-through motion. And now let's consider the coordinated movement of kicking. Kicking is similar to throwing in that there is a planted lead leg and a swinging trail leg. Again, the body must pivot around the planted lead leg in order to position the body for powerful sagittal motion. In kicking, the trail leg does not contact the ground as it does with throwing. The hip flexors and knee extensors are maximally recruited to place greatest force at the foot for kicking. The gluteus maximus, hamstrings, and adductor groups of muscles must slow this motion once the ball has been contacted. So to summarize the main points of today's lecture, the pelvic girdle is made up of the ilium, ischium, pubis, sacrum, and coccyx. The ilium, ischium, and pubis converge at the acetabulum, forming the socket of the bowl and socket coxal joint. The sacroiliac joints and pubic symphysis allow slight movement in the pelvic girdle. The head of the femur forms the head of the ball and socket coxal joint and can move in all planes to produce flexion, extension, abduction, adduction, internal rotation, and external rotation at the hip. The knee consists of two joints, the Tibial-femoral joint and the Patellofemoral joint. Together, these two joints allow flexion, extension, internal rotation, and external rotation at the knee. Movement of the patella maintains the leverage of the quadriceps muscles as the knee flexes and extends. As with the shoulder, the deeper, smaller muscles in the hip, such as the deep six external rotators, tend to stabilize the joints. The larger, more superficial muscles, such as the gluteals, create powerful movements. The inguinal region, deep posterior hip, and posterior knee contains several vulnerable structures, including lymph nodes and vessels, arteries, and nerves. Avoid these during palpation. Balance flexibility of the pelvis, hip, and thigh, enhance posture, and minimize injury such as patella tracking problems, muscle strains, and ligament sprains. Coordinated movements of the muscles of the pelvis, thigh, and knee is required during walking and running, as well as powerful movements such as lifting, throwing, and kicking. And for our assignment for this week, this is assignment number 8 for week 9. We're going to list the bones that make up the coxal joint. We're going to list the bones that make up the pelvic girdle. We're going to list the superficial muscles of the pelvis, thigh, and knee. We're also going to list the deep muscles of the pelvis, thigh, and knee. And we're going to list the movements available at the hip and knee joints. We're also going to describe how injury to the hip and knee joints would impact movement. And when you're done, you're going to place this answer in the comment section beneath this video. So my office hours, as always, are Thursdays from 4 to 6 p.m. And if you're having any difficulty at all, you can shoot me an email. And don't forget to also look for the posting on the discussion page for our channel. And I look forward to receiving your assignments and reading your comments. Do take care and enjoy the rest of your week.